Hi, Nick. Are we the only people doing it today?
Yes, Schweb. Yeah, just you guys today.
Okay. So you don't want us to stretch it out to an hour, though, do you?
No, definitely not. Not that it isn't really interesting. But, we'll be a bit more relaxed about question time.
Oh, fine. Okay, that's good. Okay. I hope you've got a list of questions you want to ask us.
Not yet. I'll be writing them down.
Okay, that's good. Okay, well, I'm sure this will be incredibly fascinating for everyone. So
it will. I know. I've had a little preliminary chat with Vera about.
Okay, that's good. Yeah. All right. Okay, good. All right. Well, I'll switch off then.
Okay, great. We'll welcome your contribution in a little while.
Yep.
Good. So, Vicky, are we ready to roll?
Yep, everyone's in now.
Everyone's in. Great. Well, hello, everybody, and welcome to this week's staff round. The bad news is we only have one presentation today. Unfortunately, the other presenter had to back out due to COVID. But the good news is we have an excellent presentation from Allergy and Clinical Immunology presented by Dr. Vera Harper, which is level pegging on behalf of Dr. Schweb Nasser. So we look forward to this. And just by way of housekeeping, to remind people to keep their microphones on mute unless they're asking a question, but put your questions in the chat room and I'll read them out at the end of the session. So we do just have the one presentation, but Vera assures me she hasn't sort of stretched it out to an hour, but we will have a little bit more time for questions, and I'm sure there'll be plenty on this interesting subject. Okay, Vera, over to you. Thank you.
Thank you very much, and good afternoon, everyone. Can you hear me okay?
Yep, it's all good.
Great. So the first case is that of a 57-year-old female who in 2011 was given aspirin 300 milligram prior to coronary catheterization, and within minutes she felt unwell, complained of palmar-plantar pruritus, facial swelling, and felt dizzy and nauseated. She was promptly treated with clofenemine and hydrocortisone, and the angiogram was completed. In 2014, whilst traveling in South Africa, she was on Malaron antimalarial, and 4 days into the course, she felt acutely breathless, had facial swelling, nausea, and a sensation of a lump in her throat and difficulty swallowing. She took an antihistamine and went to a local clinic where Malaron was stopped. Later the same year, she had an unusual reaction where she received influenza vaccine, and 12 hours later, she felt itchy all over and had a red blotchy rash typical of urticaria with facial swelling and throat constriction. She took antihistamines but did not seek further medical advice. The year after, she attended a GP surgery for a steroid injection for trigger thumb, and she received dipomedrone. Within minutes, she was flushed, had itchy palms and soles, started sneezing and felt dizzy on standing, and had urinary urgency. She then, soon after that, she collapsed but did not lose consciousness. They treated her for anaphylaxis and took her to ED, but no further treatment was given as she was feeling better. Regular medications include iron supplements, lansoprazole, and isosorbate mononitrate. She has no significant family history. So when we saw her in clinic, we did skin prick test and intradermal skin test, and these were positive to Malaron antimalarial, but dipomedrone was negative. We then proceeded for an intramuscular challenge with dipomedrone 1 milligram, as this is the gold standard diagnostic test to confirm or refute allergy. Within minutes of the injection, she was flushed, had itchy feet and ears, and then there was urticaria followed with a drop in her blood pressure from 117 to 94 systolic. We promptly treated her for anaphylaxis, and a tryptase sample taken soon after was unremarkable. Her case was then discussed in the MDT, and then we reviewed her history. And she reported that each time she used hair dyes, she had an itchy scalp and facial swelling. We then checked the excipients of the medications that caused reactions, and we found Malarone contains polyethylene glycol, also known as macrogol, 8,000. Aspirin 300 contains PEG 3350. Dipomedrone, on the other hand, contains macrogol, but the molecular weight is not listed. The flu vaccine she'd received contains polysorbate 80. After this, we quickly invited her back for PEG investigation. And again, we did skin test, and this showed positives to higher molecular weight PEGs, as you can see, 3350 all the way to 20,000. We repeated Malarone skin tests, and these were again positive. She was diagnosed with PEG-induced anaphylaxis and advised to avoid PEG in medicines, and equipped with an emergency care plan, including adrenaline, as PEG is ubiquitous and difficult to avoid. The second case is that of a 51-year-old male who in 2013 took Movicol, and within a minute he was unwell, followed 30 minutes later with generalized urticaria. He self-managed with Claritin antihistamine with limited effect, as he went on to feel lighted and lost consciousness. Ambulance crew arrived and found him profoundly hypotensive, but managed to treat him for anaphylaxis and took him to ED, but no further treatment was given. A tryptase sample taken at 3 hours post-reaction was raised, as you can see, as 57. Prior to this reaction, he had also reacted to Reni, tablets which contain macrogol or PEG 3350. Tibropase cream also contains macrogol and tended to cause urticaria each time he applied. His regular medications, we found that he was tolerating PEG, but at a lower molecular weight, as you can see, sertraline and amitriptyline. So for investigations, his skin tests were positive to Movicol and PEG at higher molecular weight, that's over 3350 molecular weight. He was diagnosed with PEG-induced anaphylaxis, and again, advised to avoid PEG and wear a MediAlert bracelet, and it was equipped with emergency treatment plan. So for all our PEG allergic patients, we tend to provide personalized care plan. We have learned over the years that PEG is ubiquitous, and therefore advising patients to avoid total avoidance of PEG is not quite practical. And because of this, we tend to try and determine each patient's PEG reactivity threshold, but this is not easy. And then after that, we assess the reactions again to determine the clinical severity. And in most cases, we advise patients to avoid higher molecular weight PEGs, as these have been reported to be highly allergenic compared to those of lower molecular weight. This, of course, requires repeated patient education, and there are written notifications that we share to both the patient and other healthcare professionals. And what this entails is that PEG is widespread in medicaments, medical devices and materials, and household products. Because of this, it's really important that all ingredients in medicines, vaccines, including preservatives, medical devices, and any tablet service coatings are checked for PEG excipient. So next, we're going to look at the use of excipients in pharmaceuticals. So what are excipients? Well, these are substances other than the active pharmaceutical ingredient that have been appropriately evaluated for safety and intentionally included in a drug delivery system. They range from innocuous and simple to active and complex substances that can be difficult to characterize. They can be categorized in many ways, for instance, by route of administration and origin. For instance, those derived from carbohydrates, proteins, or petrochemicals, etc. Their roles range from binders, diluents, all the way to colorings or sweetness. But this essentially depends on the drug formulation, as they help in manufacturing process to where they protect and enhance drug stability for bioavailability and patient acceptability. They are also helpful for drug identification and overall safety and integrity of the product during the storage process and delivery. Now, if we look at PEG and polysorbate 80, what are these excipients? So PEG, as mentioned, is polyethylene glycol, also known as macrogol. And the molecular structure you can see there, PEG is derived from ethylene oxide, which has a molecular weight of 44 Dalton. When this reacts with water, monoethylene glycol is produced, and polymerization of monoethylene glycol leads to production of PEG, and this can be of varying chain lengths and molecular weights. Polysorbate 80, on the other hand, is a derivative of PEG, and this is similar to poloxamer. Both are used as stabilizers in products, household products, medicines, and with polyethylene glycol, they've been found to be hydrophilic polymers. And if you look at the highlighted chemical moieties, that this one and this one here, common in both compounds, polysorbate 80 and PEG, there are reports to show that this may, in theory, suggest cross-sensitization. And this is where there's been a lot of concerns whether patients who are allergic to PEG can be safely given medicines containing polysorbate 80. However, there are also reports to suggest that polysorbate 80 is less allergenic, and this is because it has a lower molecular weight. PEG's molecular weight range from 200 to 35,000 kilodaltons, and they reported that the higher the molecular weight, the more allergenic the compound is. And this is our experience as well. Wenand and Gavi, a team from Denmark, reviewed case reports published between 1977 and 2016 and found that there were 76% reports that met the criteria of anaphylaxis. But there was a revision by the FDA data, which showed that an average of 4 cases of anaphylaxis per year are due to PEG, suggesting that this might be a tip of the iceberg. So, in cases of suspected PEG allergy, identifying the content of PEG in a drug or product is critical. But unfortunately, this is not always straightforward because the nomenclature is confusing. For instance, in the cosmetic industry and pharmaceutical topical drugs, PEG is labeled with average number of ethylene oxide. As you can see, Dactacot is labeled as PEG 38. 38 stands for the number of ethylene oxide units. To calculate the molecular weight, you multiply the ethylene oxide units by 44, which is the molecular weight of ethylene oxide. The pharmaceutical industry, by contrast, refers to the rounded average molecular weight. For instance, Movicol is PEG 3350. So what we try and do is determine each patient's reactivity threshold, and if the PEG is labeled with ethylene oxide units, we calculate the molecular weight. So PEG This is just showing that PEG is found in so many medicines, common medicines. And I just wanted to highlight that Gaviscon double action at the bottom, which is found over the counter, contains PEG 20,000. Other common agents are Pen-V, clopidogrel, laxatives, and one that can easily be missed is the transvaginal ultrasound gel. In order to accurately identify the PEG content in a drug or a device, it's important to obtain the brand name and the manufacturer. After this, you can then cross-check the list of excipients online on the Electronic Medicines Compendium. And this is section 6.1. So how big is a problem, the PEG allergy problem? Well, there are 2 reported fatalities that needed a coroner review. The case on the left is in the Irish Times, was that of a 60-year-old male who died of anaphylaxis in 2015. Now, this patient had been diagnosed with PEG allergy following anaphylaxis to intra-articular steroid injection to his ankle the preceding year. During this event, he had attended to the hospital, but unfortunately the staff were not aware about PEG allergy. But since the incident, the hospital has introduced measures to help avoid this. The case on the right is not too far from us, it's in Kettering. This happened in 2019. This was a 53-year-old man who suffered a myocardial infarction, and within 24 hours, he was undergoing coronary angioplasty plus stent insertion. And mid-procedure, he had severe anaphylaxis. Unfortunately, they were not able to resuscitate him. Prior to the procedure, the staff had checked all the medicines, all the equipment, and was satisfied that there was no PEG. Unfortunately, there was PEG hidden somewhere. The interventional cardiologist wrote to the manufacturers, and it was later confirmed that there was PEG in some of the wires that were used for stenting. This obviously highlights that PEG is hidden in some cases, and labeling of products, including devices, is not always correct or done comprehensively. The case was reported to the MHRA, and changes have been made and continue to be made. How about allergy to polysorbates? Is there cross-reactivity between polysorbates and PEG allergy? Well, this is currently a topical issue, especially with COVID vaccines in PEG allergic patients. In 2020, the CDC announced that patients with a polysorbate allergy must avoid Pfizer and AZ vaccines, AstraZeneca vaccines. And you can imagine this has led to concerns because COVID vaccines that were initially licensed contained both PEG and some contained polysorbate 80. What we know is polysorbate 80 or polysorbates generally are known to induce anaphylaxis-like reactions in animal models. But in humans, we are only aware of one case of HPV vaccine-induced anaphylaxis. Now, HPV contains polysorbate 80. However, there are lots of case reports pertaining to IgE sensitization without clinical reactivity. Here you can see various medications containing polysorbates. There's mostly childhood vaccines and some influenza vaccines and biological agents. The amount of polysorbate 80 in AstraZeneca vaccine is slightly less than the amount in influenza vaccines. So going back to our cases, the first case and the second case, they were both diagnosed with PEG allergy. And after vaccine rollout, they were advised to avoid mRNA vaccines, which is Pfizer and Moderna. We then invited them for further testing. And the first case, the 57-year-old lady, tested positive to both polysorbate 80 and AstraZeneca vaccine. The male patient tested negative. So just to go back to briefly talk about the potential allergenic excipients in COVID vaccines. So PEG is found in mRNA vaccines, that is Moderna and Pfizer vaccines. Within the mRNA vaccines, you have two lipid nanoparticles, and one of them is pegylated with PEG 2000, and this encapsulates the mRNA to prevent enzymatic degradation during the carrier process. In polysorbate 80 is found in Janssen and AstraZeneca vaccine. Again, it acts as a stabilizer. Now, following this, the concerns were COVID vaccinations, especially in the first patient who was positive to both AstraZeneca vaccine and polysorbate 80, given the potential cross-reactivity. So what we did is discussed the risks and benefits, and patient had some time to have a think, and she was brave enough and consented for vaccination. So we did this cautiously, giving her 20% of the AstraZeneca vaccine dose, followed 30 minutes later with the remainder of the dose. The second patient was straightforward, given the negative skin test, and he tolerated the AstraZeneca vaccine. However, there remains concerns around vaccinating PEG allergic patients with polysorbate 80 containing vaccines, given the theoretical risk of cross-reactivity. This is currently topical because clinical allergy remains to be established. In terms of our experience locally, we, over the last year, we invited 8 PEG allergic patients, and they had skin tests to both polysorbate 80 and AstraZeneca vaccine, and 6 of those patients tested negative to both agents. 1 was positive to polysorbate 80 only, and 1 was positive to polysorbate 80 and AZ vaccine. All the patients were successively vaccinated with polysorbate 80 vaccine AstraZeneca. We published this data at the clinical and experimental allergy to ensure that as many patients who are PEG allergic are vaccinated with polysorbate 80 containing vaccines. Colleagues from Denmark also have reported similar findings, where 10 PEG allergic patients successively received Janssen COVID vaccine, which contains polysorbate 80, following skin testing. So the take-home messages from this talk is that cross-reactivity between PEG and polysorbates has been suggested, but clinical correlate is yet to be established. What we know is PEG allergic patients can now be safely vaccinated with polysorbate 80 containing vaccines as AstraZeneca and Janssen. PEG allergic patients are to avoid mRNA COVID vaccines. And if there are any patients suspected to be PEG allergic, the main important thing is to take a thorough history. And most of these patients, if they are indeed PEG allergic, they would have suffered anaphylaxis to multiple structurally different drugs and household products. Thank you for listening. I welcome any questions.
Vera, thank you very much indeed. Really interesting and useful findings that you have there to potentially reassure people with PEG allergy regarding vaccinations containing PS80. I encourage people to put some comments into the chat or questions into the chat. Maybe I can start while people are coming forwards. In the two cases you presented, one of them only had reactivity to intramuscular PEG, I believe, rather than skin prick testing. That's correct?
Yes. So she received dipomedrone,
right?
Initially intra-articular injection, and had a reaction. But during testing, Malaron skin test was positive, but when we did an intramuscular challenge, that was positive with clinical reaction, but the skin test to dipomedrone had been negative.
Yeah, okay. I guess my question related to that is when you came to do your kind of your evaluation of the patients who were PEG sensitive, you chose to do skin prick testing rather than what you said was the gold standard, which is intramuscular testing. What's the thinking there?
So with the testing, obviously AstraZeneca vaccine no one had ever received it before, so this is new. And what we know for clinical allergy, in most cases, not always, one has to have been exposed to the allergen or the drug, as it were.
Great, thank you, Vera. So a question from Paul Edelstein. Why is the positive predictive value of skin testing apparently low for parenteral drug administration, such as vaccines?
Nick, can I chip in here?
Yeah, please do, Shweb. Thank you.
Okay, so I think that both of these questions are related. Your question and also the question on the chat. And the question is, how useful is skin testing with various agents? And each agent will have individual positive predictive values for skin prick testing, intradermal testing, and whether you need to undertake a challenge. And in this particular case, to depomedrone, we had to challenge the patient to intramuscular depomedrone because the skin tests were negative. And there are lots of reasons for skin tests being negative. It may not be an IgE-mediated mechanism, but that's not the case in this particular case. It's possible that the concentration of PEG was too low in the skin test solution, in which case it wouldn't produce a positive skin test. We've found over the years that we can only do well, that the higher the molecular weight, the more likely the skin test is to be positive. The greater the concentration, the more likely the skin test is to be positive. Obviously, the more sensitive the patient is, again, the more likely the patient is to be positive. The other thing that we've discovered is that if we do intradermal tests, then almost always the patient develops anaphylaxis on intradermal testing. And unfortunately, we've caused anaphylaxis on a number of occasions in some of these patients. So the diagnosis isn't easy. It isn't easy to make. We've got to be ultra cautious. One thing that's clear about these cases is that the amount of polysorbate in the AstraZeneca vaccine may be too low to cause an allergic reaction. And I think that relates to the question on the chat. But no one knew this before we embarked on this journey. And we now know that PEG, all of our PEG allergic patients can have polysorbate in vaccines, and particularly in this particular vaccine. So it allowed them to be vaccinated against coronavirus. So that was quite useful.
Yeah, thank you, Shweb. Okay, any further questions in the in the chat, please. What about IgE levels? Is that at all useful in this situation? Are there PEG-specific IgEs?
So so just to answer that, currently we don't have any validated IgE assays for use, but hopefully this is something that is in the pipeline and should come out sooner.
Right.
We are developing them, Nick. We are developing an IgE test. The FDA actually has an IgE, a specific IgE test, and we have collected some blood to send to the FDA in the States. They've reported on a few cases, and they're also looking at IgG. The reason IgG is relevant is because some reactions to polyethylene glycol or to the vaccines may be via IgG PEG reactions and complement activation via the classical pathway. So that may be also another mechanism. I mean, I'm sure you've all heard of multiple adverse reactions and allergic type reactions to the COVID vaccines, but it does appear that a very small minority of them are true allergy.
Thanks. So Ken Smith is asking, how closely is PEG allergy associated with atopy and the likelihood of other allergies?
Not at all. Absolutely not at all. There's completely no relationship at all. So many of our patients are not atopic. Some of them are atopic, so it doesn't seem to be related.
Okay, thank you. And can you comment on the labeling? And you mentioned that sometimes it's a little mysterious. I mean, is there a sort of statutory requirement for labeling of PEG and its molecular weight in medical products? But does that extend to over-the-counter products, cosmetic products, and so on? What's the...
Well, that's a really good question, Nick. And the reason it's good is because each of our patients has a different level of sensitivity. Some of them literally have, they develop severe allergic reactions to tiny quantities of PEG in tablets, on using topical products. And so we've got to take a nuanced approach, but some of our patients are only allergic to PEG 20,000 in Gaviscon double action. And in fact, that particular patient who developed anaphylaxis with Gaviscon double action, he is currently taking a drug daily that contains PEG 6,000. So everybody has a different molecular weight threshold, and everybody has a different amount that leads to anaphylaxis. The other thing that's really interesting about this is that the higher the molecular weight, the less gets absorbed through the gut. Because if you think of Movicol, for example, in which the active ingredient is PEG 3350, only about 1% of it gets absorbed. So the higher the molecular weight, the smaller the amount that gets absorbed. And so this does become actually quite challenging in order to provide a nuanced approach with each patient.
Yeah.
But the MHRA has probably not been effective in the past. You'll find drugs that have labels with molecular weight, but none of them have an amount. And it really came to the fore when this particular patient died during coronary artery angiography at Kettering General recently. And now the MHRA are convening an expert working group where they're going to look at the whole question of labeling and exactly what needs to be labeled. So things, I hope, are going to change. And we're trying to get the same changes across EMA and FDA. So we're trying to have an international response to this.
Great, thanks. Colin in the chat asks a related question, and maybe just to expand on that slightly, because you answered some of that. How do you actually get a patient to understand, and how do you advise them on this? Because we're talking about some quite complex things, aren't we? Sort of different size, different molecular weights, different excipients. What do you actually tell them? Do you have a fact sheet or something that you can provide them with on this?
Yeah, I mean, they have to go to university and get a degree in PEG first of all, and that's the only way we can get them to sort this out. And actually, that's a serious question, and that's why we provide. This is probably one of the few drug allergies in which we provide adrenaline. I mean, if you're allergic to penicillin, even if you have life-threatening anaphylaxis, we don't provide you with an adrenaline auto-injector. this is the sort of thing that we expect patients, we almost expect patients to have repeated episodes of anaphylaxis. And that is also one of the reasons why this has become such a massive issue in terms of the COVID vaccines, because when they were first rolled out, on the first day, there were 2 so-called anaphylactic reactions. And then the story then came out was that if you developed anaphylaxis or allergic reactions and you didn't know the cause, then you may be allergic to the COVID vaccines. So you can imagine there are about 3 million people across the country who developed urticaria or angioedema, idiopathic, and they were being denied and they were not willing to take the vaccines. So we've had to change the mindset over the past 13 months, and that's effectively what we've done. So it has been a challenge. It's been difficult, but you're absolutely right. We basically tell people, depending on their previous reactions and which drugs they tolerated and their skin test results to the different molecular weights, we tell them to look out for certain things, certain molecular weights, and to basically only take PEG containing drugs that they've previously taken and tolerated. Otherwise, they've got to avoid the lot.
Great, thank you very much indeed. Good, so I don't think we have any more questions. This is your last chance. Everybody gone. Okay, well, we're 25 to the hour, so we've had a good discussion there. Just remains to thank Dr. Harper and Dr. Nasser. Thank you very much indeed for excellent presentation, really useful work. Really great to see this being presented. Thanks everybody for joining us, and see you next week.